Good morning, ladies and gentlemen. Welcome to the Dr. R.L. Spittel Oration for the year 2023. Please rise as the ceremonial procession enters the auditorium. Please do take your seats, ladies and gentlemen. I call upon Professor Nandadeva Samarasekara, the President of the College of Surgeons of Sri Lanka, Professor Sanjeeva Seniviratne, the Secretary of the College, and the R.L. Spittel Orator, Dr. Umesh Jeyarajah, to come to the stage. Dr. Sanjeeva Seniviratne, the Secretary of the College of Surgeons of Sri Lanka, will now formally introduce the Dr. R.L. Spittel Orator to the House.
Good morning, everyone. President and the members of the Council of College of Surgeons of Sri Lanka, ladies and gentlemen. Dr. Umesh Jeyarajah, MBBS Colombo, MD Colombo, MRCS Glasgow, FMAS India, who is currently a Senior Registrar in General Surgery with a special interest in endocrine surgery at the Professorial Unit Surgery, Colombo. Dr. Jeyarajah has a brilliant academic career. He graduated with MBBS from University of Colombo with first-class honors in 2015, winning several medals, including Dr. M.N. Buran Gold Medal for Surgery, awarded for the best performance in surgery, and Garvin Gold Medal, awarded for the best performance in operative surgery. So he showed that he is on his path to become an excellent surgeon from very early days in his training career. So then he completed MD Surgery in 2021, obtaining Dr. M.H. D'Souza Memorial Medal, awarded for the best performer in theory component at MD Part 2 surgery exam. Following which, he obtained MRCS from the Royal College of Surgeons and Physicians of Glasgow in 2022, FMAS, that is Fellowship in Minimal Access Surgery in India, in 2023. Most important thing about Umesh is he's an excellent researcher. He's a researcher par excellence, starting from very early days of his professional career. Currently, he has over 150 index journal article publications. I repeat that, over 150 index journal article publications with over 4,400 Google Scholar citations with an H index of 31 and I10 index of 63. These are absolutely amazing figures for a junior surgical trainee like Umesh. In recognition of his research, last year, he was selected as one of the top 2% of researchers in the world. Again, I repeat, he was selected as one of the top 2% researchers in the world, in which brought recognition not only to the university, which he is part of, but to the country and surgical fraternity of Sri Lanka as a whole, because he is the first only Sri Lankan surgeon to be included in that list. Furthermore, he has won several other awards for his research, needless to say, which are too numerous to mention. He has a long list of awards which he has won, but I will mention a few. He had been the winner of Dr. Pierre Anthony's Research Award given by our college for the best research publication by a surgical trainee over the last 3 years. It has essentially become his default. He is the default winner of the medal, which he won last night as well. In addition to that, he has won S.J. Stephen Award for the best published article in the Sri Lanka Journal of Surgery in year 2021. He was also awarded HSC Open Access Research Award in 2022 by the Irish Health Services Executive to a research publication for its impact on health service provision in the overall winner category. In addition to that, he was also awarded Presidential Award for Scientific Publications, which is the highest award awarded by the the National Research Council in 2022 in recognition of his research. He's an active member of our college as well, and he's currently working as an assistant editor for the Sri Lanka Journal of Surgery, and he's also the junior editor for our official newsletter, Suture. On a personal note, I got to know Umesh when he was working as a research assistant with Prof. Nandadeva Samarasekara in 2015. Over the last 8 years, I have personally witnessed how he blossomed to become one of the best surgical researchers in the country. Very soon, I'm quite sure he's going to be the best surgical researcher in the country. I have no doubt about that. So it was an absolute joy, Umesh, to have worked with you and shared some of the research projects with you over the last few years. And now, he has recently joined our department, so I'm absolutely happy that he's going to be my future colleague. So, on behalf of the President and the Council of the College of Surgeons of Sri Lanka, it is my pleasure to call upon Dr. Umesh Jeyarajah to receive Dr. R.L. Spittel Medal from Professor Nandadeva Samarasekara, our President, to deliver R.L. Spittel Oration today.
Thank you, sir, for your kind words of introduction. President and the Council of the College of Surgeons of Sri Lanka, family members of Dr. R.L. Spittel, my most respected teachers and mentors, colleagues, friends, ladies and gentlemen. First and foremost, I wish to extend my sincere gratitude to the President and the Council of the College of Surgeons of Sri Lanka for giving me this opportunity to deliver the prestigious R.L. Spittel Oration for the year 2023. I consider this as a great privilege bestowed upon me to honor an eminent Sri Lankan surgeon, Dr. R.L. Spittel. Dr. Richard Lionel Spittel, CMG, CBE, LMS, FRCS, was born in 1881 in a remote village in Tangol in southern Sri Lanka. After completing his secondary education at the Royal College, Colombo, he entered the Colombo Medical Faculty and graduated in 1905. Subsequently, he moved to England, where he completed the conjoined diploma in 1908 and then Fellowship of the Royal College of Surgeons of England in 1909. Thereafter, Dr. Spittel returned to Sri Lanka to assume duties as a third surgeon at the General Hospital Colombo, which is now known as National Hospital Colombo, Sri Lanka. Dr. Spittel was a pioneering surgeon. He performed wonders in an era when medical facilities in Ceylon were rather primitive, and speed as well as accuracy were essential prerequisites for a good surgeon. Dr. Spittel was the first to perform a skin graft in Sri Lanka and was the first to perform a blood transfusion using his own blood. Dr. Spittel was a scholar. He did research on diseases prevalent in Sri Lanka at that time and published many medical books. Some of the well-known medical books include Basis of Surgical Ward Work in 1915 and Essentials of Surgery in 1932. Dr. Spittel was a surgeon with a multitude of skills. Apart from being a scholar and a teacher, he was a naturalist and a prolific writer. Dr. Spittel had an innate love towards anthropology and jungles of Ceylon and its native inhabitants, the Vedas. He was one of the foremost personalities who recognized the need to record the customs of Vedas who lived lives as close to their ancestors. He became a close friend of Vedas while studying their lifestyles and customs by living amongst them. Over a period of 4 decades, Dr. Spittel published many books on historical aspects of Sri Lanka and, of course, the Vedas. Some of the well-known books which many of us have read and enjoyed include Wild Ceylon, Savage Sanctuary, Vanished Trails, Where the White Sambo Roams, and The Wild White Boy. Dr. Spittel died in 1969. His life was beautifully summarized in the obituary notice published in the British Medical Journal the same year. I quote, "Those steeped in Western culture went off the beaten tracks of clubs and tennis courts into the wilderness, where Ceylonese customs, traditions, arts and crafts were studied and revealed to the world," I unquote. Commemorating his exceptional contribution in multiple fields of expertise, a stamp was released. Dr. R.L. Spittel's book, entitled Essentials of Surgery, was famous during his time among the surgeons and medical students. In his book, he has a dedicated chapter describing various types of cancers, its clinical features and management. The images illustrate several patients who presented with advanced malignancies which we do not see commonly in present day due to early presentation. With that note, I proceed with the topic of the oration, Epidemiology and Care of Surgical Cancers in Sri Lanka. In this oration, owing to the time constraints, I will attempt to present my findings with brevity and clarity. The detailed oration will be published later for your perusal in the Sri Lanka Journal of Surgery. Rising burden of cancer is a major challenge in the developing world. In 2020, 19.3 million new cancers were estimated, and it was one of the leading causes of mortality with 10 million deaths. Similarly, in Sri Lanka, the newly diagnosed cancer cases has increased by twofold over the last 3 decades. According to the Global Care estimates in Sri Lanka, in 2020, 29,000 newly diagnosed cases and 14,000 deaths were predicted, and these figures are expected to rise. This figure shows the rising incidence of cancer among males and females in Sri Lanka. This may be partly explained by the increased diagnosis and reporting of cancer due to efforts of the National Cancer Control Program. Nevertheless, regardless of the cause for the observed rising incidence, this poses a significant burden on healthcare, including the surgical facilities that treat cancer patients. There are several strengths of cancer care in Sri Lanka. Due to the effective public health network and universal free healthcare across the country, Sri Lanka is known for its commendable achievements in health outcomes compared to the neighboring low-middle income countries, despite a relatively low total healthcare expenditure. Regional and provincial centers, as shown in the figure, are available with an oncologist, surgeon, radiologist, and pathologist with other auxiliary services to treat cancer. Furthermore, a rigorous training program in the field of oncology and other oncological related services are offered in Sri Lanka, building up the necessary staff to manage cancer patients. While this success is noteworthy and commendable, it is imperative to identify the current challenges faced by Sri Lanka to cater the burden of cancer. These include lack of formal palliative care, limited radiation facilities, limited health technology assessment, which is needed to assess cancer care and identify treatment priorities, and very limited local research. How do we tackle the current increasing burden of cancer? It is by assessing the incidence, trends, outcomes, cancer care, and cost effectiveness, thereby optimizing the existing health resources to cater the changing cancer epidemiology. Therefore, quantification and documentation of the trends of the incidence of cancer is essential for the policymakers for the distribution of resources. Moreover, surgical cancers have a special need in terms of additional resources for specialized surgery with pre-op and post-op care with long-term management of morbidity and complications due to surgery. Therefore, this oration is aimed to describe the trends and patterns of incidence rates of common surgical cancers in Sri Lanka, supported by additional data from cohort studies regarding the clinical patterns and outcomes, while providing recommendations for future cancer care. So, we analyzed the National Cancer Registry data, selecting common cancers in Sri Lanka with high incidence that require surgical resection, specifically cancers of the breast, thyroid, oropharynx, GI tract, hepatobiliary system, and the urological system. Details of specific cancers between 2001 to 2019 were extracted from the compiled data published by the Sri Lanka Cancer Registry. The trends, patterns, and the incidence were quantified and analyzed by joint point regression software. Additional findings from cohort studies, including individual cancer patients from National Hospital of Sri Lanka and Apesha Hospital, Maharagama, was used to back arguments and support recommendations. The ethical clearance was obtained from relevant institutions. This table summarizes the incidence and trends of common cancers in Sri Lanka. The commonest cancer is breast cancer, followed by thyroid, oropharyngeal, and colorectal cancers. Considerable disparities in change in incidence with gender were shown among the highlighted cancers. Average age was relatively low among the thyroid and renal cancers, and the highest incidence of thyroid cancer, which is the second commonest cancer, was shown in the young age group, that is 35 to 39, which is much less compared to the other cancers, which occurs relatively in the elderly population. Breast cancer. Breast cancer is the commonest cancer among Sri Lankan women, and we have noted a rising trend in incidence both in female and male breast cancers. These publications can be seen in the BMC Cancer Journal. Comparing pre- and post-menopausal women, we initially found that from the analysis from 2001 to 2010, only a modest rise in incidence among the younger women with breast cancer was shown. However, analysis up to 2019 revealed that the incidence among younger women is also increasing at a greater rate compared to older women. This will have considerable implications in screening. We performed a cohort study from Apesha Hospital, Maharagama. We analyzed 5,181 women with newly diagnosed breast cancer with a mean age of 56 years. We found that around 2/3 of the breast cancers were diagnosed at an early stage, stage 1 and stage 2, which is much less compared to Western data, which is over 90%. The ER, PR, and HER2 positivity rates were seen among 72 and 22% respectively. 2/3 of the patients underwent mastectomy, and another 2/3 underwent axillary clearance. The population that had a wide local and reconstruction is significantly lower compared to the Western population. We observed considerable lapses in the concordance between guideline recommendation and the delivery of cancer care among breast cancer patients in Sri Lanka. Around 90% of females with node-positive disease received chemotherapy, while 77% those indicated had received adjuvant radiotherapy. Furthermore, the rate of endocrine therapy was seen in 88. However, HER2 positivity patients, only 60% received trastuzumab. The reason for this may be multifactorial, including access limitations, patient comorbidities, and socioeconomic factors, and poor health literacy. So this warrants closer assessment and intervention. Thyroid cancer is the second commonest cancer in Sri Lanka, and we noted a rising incidence with variable trends among males and females over the last 20 years. Females had a greater change in incidence than males, and this was published in the BMC Cancer Journal. Oropharyngeal cancer is the third commonest cancer, and is the commonest cancer among males. And the important thing is it's a preventable cancer. So this oropharyngeal cancer, we have shown a rising trend over the last 20 years, and the trend was significantly higher among males compared to the females. We also analyzed esophageal and gastric cancer in Sri Lanka, and these publications can be found in the European Journal of Cancer Care and the Asia Pacific Journal of Clinical Oncology. We noted a rising trend in both gastric and esophageal cancers. However, the trend in females was variable. The important finding is that although squamous cell carcinoma of the esophagus was the commonest, around 90%, greater increase in adenocarcinoma is noted among our population over the last 2 decades. Colorectal cancer is the fourth common cancer in Sri Lanka, and it has also shown a rising trend, and there is no significant male versus female disparity. This publication you can find in the European Journal of Cancer Care. We noted that the majority were in the left colon, about 70%, and the right colon consisted of only 30% of colorectal cancer. We analyzed a cohort of colorectal cancer patients from Maharagama over the last 5 years, and we found that the majority were colon cancers, 53%, and rectal cancers was 47%. Stage 1, 2, 3, 4 was observed among 13, 28, 46, and 12% respectively, and the majority was seen among the stage 3 cancers. Adjuvant chemotherapy was administered to 82% of stage 3 cancer patients. However, neoadjuvant chemoradiotherapy was delivered to only 50% of patients with stage 3 rectal cancer, which should be much higher than this. Possible reasons for this incongruence may be due to limited access to radiotherapy, upfront surgery performed in smaller hospitals, and patient comorbidities, emergency presentation, socio-economic factors, and poor health literacy. We analyzed the liver, biliary, and pancreatic cancer and found to have an overall rising trend. And these publications can be found in the the South Asian Journal of Cancer and the Indian Journal of Cancer. The possible reasons are likely due to increased radiology facilities for guided biopsies, better facilities for surgery, and better reporting for these malignancies. So we analyzed the bladder cancer and renal cancer patients, and it showed a variable trend. Initial rising period followed by a slight decline. The males had a higher rising trend in bladder cancers, whereas in renal cancers, females had a greater rising trend. We also analyzed the bladder cancer patients individually at National Hospital of Sri Lanka over the last 10 years, from 2007 to 2017. And we found that the majority were urothelial cancers, around 92%, and the high-grade patients, high-grade cancers were seen among 55%. And PT2 or more, that is muscle-invasive cancer, was seen in around 1/3 and non-muscle invasive in 2/3. PT1 high grade, which is a special group of bladder cancer, was noted in 17.5%. Although women had a lesser occurrence of bladder cancer in our cohort, we noted that more aggressive features, such as higher non-urothelial and muscle-invasive cancers, were present among them. These publications can be found in the Ceylon Medical Journal. A rising trend in incidence was noted in prostate cancer, followed by the plateau in the last 5 years. The possible increase in incidence is likely due to the better guided biopsy facilities and surgical facilities to diagnose and treat prostate cancers in Sri Lanka. And this may have implication in opportunity screening because prostate cancer has now become the 5th commonest cancer among Sri Lankan men. So in our analysis, analysis of data from 2001 to 2019 revealed a steadily rising trend in the incidence among breast, HPV, oral, and renal cancers. Cancers of the colon and rectum, thyroid, prostate showed a predominant rising trend, followed by a plateau in the last few years. These trends are likely due to the combination of better reporting and diagnosis, and also a true increase in incidence. Highest incidence was shown among the growing elderly population in Sri Lanka, which is a significant finding. Several changing patterns and trends were noted during the last 2 decades, with the emergence of breast and thyroid cancers overtaking oral cancers as the predominant cancer in Sri Lanka. Analysis of a cohort of breast, colon, and bladder cancer patients showed that the diagnosis of malignancy was at a more advanced stage compared to the Western population. Furthermore, the concordance with the treatment guidelines was suboptimal among breast and colorectal cancer patients. Primary prevention for common cancers in Sri Lanka. Tobacco use, chewing of betel quid, alcohol, and obesity as a result of unhealthy diet and physical inactivity are some of the major preventable causes. It is commendable that tobacco smoking in public places and advertisements were banned in Sri Lanka. Although smokeless tobacco and betel chewing is a major predisposing factor for oropharyngeal cancer and upper gastrointestinal cancers in Sri Lanka, there are cultural barriers in banning it completely. However, measures should be taken to ban smokeless tobacco to prevent upper aerodigestive cancers. Vaccination against hepatitis B, which is a preventable risk factor for hepatocellular carcinoma, has achieved a target of 99% and has been incorporated in the national vaccination program for many years, which is commendable. Minimizing exposure to carcinogens is given priority in prevention. However, much greater importance is essential to manage, minimize, or prevent metabolic risk factors that include dietary factors, physical inactivity, and obesity. These are crucial modifiable risk factors to prevent highly prevalent cancers in Sri Lanka, including breast and gastrointestinal malignancies. Encouraging a healthy lifestyle by mass education using various media is therefore imperative. Screening. The National Cancer Control Program delivers screening programs for selected malignancies such as breast, oral, and cervical cancers. Sri Lanka lacks enough mammographic screening, lacks enough community-based mammography screening for breast cancer, which is the commonest cancer in the country. Clinical and self-breast examination is promoted as an alternative, while mammography screening is offered in several government hospitals and few private hospitals. Although clinical breast examination is readily offered in well-women clinics, such facilities are underutilized. Based on these findings that younger breast cancers are rising, women over 40 years may be advised to undergo at least a clinical screening for breast cancer annually. Based on our cohort, around 66% presented with early breast cancer, which is much less compared to Western world. As survival is dependent on staging, early detection via screening becomes essential. Similarly, community-based screening centers for oropharyngeal cancers are conducted island-wide. However, studies have shown that the compliance and adherence to screening seems suboptimal. Screening should be offered to all the individuals with exposure to carcinogenic risk factors, including the rural areas where smokeless tobacco consumption is prevalent. Establishment of endoscopy screening has been established in high-income countries with a high prevalence of cancers of upper and lower gastrointestinal tract. Currently, similar screening programs for endoscopy or fecal studies are not established in Sri Lanka due to resource constraints and relatively low incidence. However, owing to the rising incidence of colorectal and esophageal and gastric cancers, opportunistic screening via endoscopy or fecal testing should be offered to symptomatic individuals aged over 40 years based on our incidence patterns. As the majority of cancers are found in the left colon, screening with sigmoidoscopy can be considered as an alternative for colonoscopy in the context of limited resources. Prostate cancer showed a rising trend in the incidence and has become the 5th commonest cancer among Sri Lankan men. Although there is no established screening program, prostate-specific antigen-based opportunistic screening program should be encouraged among surgeons and general practitioners among fit, older men with low urinary tract symptoms. With regard to diagnosis and treatment, although facilities for medical oncology has been established in every district general hospital in Sri Lanka, there is a lack of radiation oncology facilities. Restriction of radiology oncological facilities to few hospitals may lead to increased waiting time, cure rate, and default rate. Therefore, increasing the radiation oncology facilities is an urgent need. Cancer care with multidisciplinary approach is less commonly practiced in Sri Lanka. Different specialties such as surgery, radiology, pathology, and oncology usually function independently to treat the same patient. Therefore, we should look forward to developing a multidisciplinary culture. Currently, there are no dedicated breast and endocrine cancer centers, despite these being the top 2 cancers in Sri Lanka. Certain cancers, such as those arising from the hepatobiliary tract and the urological system, need specialized expertise and resources in managing these patients. Thus, establishing specialized dedicated cancer centers with formal referral pathway is a timely need. Ancillary services such as minimally invasive radiology, immunohistochemistry, and molecular diagnostics are important in certain cancers. Guided tissue sampling methods are important in hepatobiliary cancers to obtain histological diagnosis prior to chemotherapy. Furthermore, lack of tissue diagnosis leads to underreporting of these cancers. Therefore, and furthermore, immunohistochemistry facilities are imperative for cancers of the breast to determine hormone and other receptor status. Therefore, increasing the resources for immunochemistry is an urgent need to cater the rising incidence of cancer, especially breast cancer. Most cancers in Sri Lanka are treated based on globally accepted guidelines formulated by developed nations. However, already local guidelines have been developed by the NCCP for common cancers such as oral, breast, esophageal, thyroid, colorectal, and prostate cancers. However, more local evidence should be generated to enrich these guidelines to suit our local setting. The cohort analysis of breast and colorectal cancers revealed considerable lapse in the concordance with the guidelines in terms of administration of neoadjuvant and adjuvant chemoradiotherapy. Establishing nationally accepted local guidelines may reduce such discrepancy. In Sri Lanka, the National Cancer Registry governed by the NCCP is the most extensive database for cancer. However, there are challenges of obtaining data related to mortality. Population-based data on mortality has been recently made available for the Colombo district. Although challenging, obtaining nationwide data regarding cancer mortality will give important insight to mitigate the increasing burden of cancer in Sri Lanka. It is documented that characteristics of cancer in this region may be dissimilar to the global data due to genetic and socio-cultural variations. Thus, original studies from Sri Lanka in these aspects are a timely necessity. The numerous studies that are conducted in small centers are laudable. However, are inferior to multi-center collaborative studies. In the era of big data, collaborative initiatives should be established incorporating multiple centers and specialties nationwide to generate high-quality practice-changing evidence. Although curative services receive substantial emphasis by the authorities and clinicians, palliative services are also equally important. Such palliative services are established only in selected tertiary care hospitals in Sri Lanka, and community-based palliative care is extremely lacking. According to the analysis of incidence, most patients with cancer are diagnosed at an age above 70 years. Such patients with comorbidities may not be suitable for major resections despite resectability and will therefore need palliative care. With the rising incidence of cancer and increasing population of elderly in Sri Lanka, the number of patients needing palliative care is expected to rise exponentially. Thus, establishment of both tertiary hospital and community-based palliative care services is an urgent need in Sri Lanka. Education of the public and health literacy is imperative for primary prevention, participation in screening, and compliance to treatment. Credible information should be provided by the experts without inducing unnecessary anxiety among the healthy public. In this era, the public seek information from internet which may be of suboptimal quality and lack updated information. Publishing online information for common cancers is a welcome initiative by the NCCP. However, more focused information on common malignancies compiled by local experts based on local practices in relation to treatment will be very useful. There are several limitations in our analysis. The technological advancement over the years would have caused an increase in the diagnosis and data collection, which might have contributed to reported increase of cancers. However, such increase was not observed in some cancers, which may support the argument of possible true increase in incidence. Collection and analysis of mortality and staging data by the NCCP in the future may help to overcome this limitation. There are several limitations in the cohort studies, including breast, colorectal, and bladder cancers. Incomplete and missing data was noted in the treatment modalities and adjuvant therapy among breast and colorectal cancers, and considerable loss to follow-up in the bladder cancer patients. However, such limitation would have negligible influence on the reporting of the disease characteristics and staging, which is more relevant to this analysis. So, ladies and gentlemen, a rising incidence of surgical cancer has been observed for most malignancies. Therefore, further research to accurately assess cancer burden, quality of care, and identify new strategies should become a priority. With the rising incidence, more robust screening, community-based screening programs for selected surgical cancers should be considered. Expansion of the coverage of National Cancer Registry is needed in terms of cancer-related mortality. With the rise in surgical cancers, more facilities for curative surgical services, radiation oncology, and ancillary services are needed. Multidisciplinary care with organized referral pathways to dedicated surgical centers providing specialized cancer care should be implemented. Establishing a nationally accepted local guidelines may reduce the discordance with guidelines. However, further studies are needed to study other factors that may have led to this observation. Furthermore, a rising incidence of malignancies, especially among the elderly in an aging population in Sri Lanka, implies an increasing population of incurable cancer needing palliative care. A lack of tertiary care and community-based palliative care facilities is a major concern in Sri Lanka and should be addressed urgently. So, ladies and gentlemen, all that I presented today is by no means an individual attempt, and it was indeed a collective effort. First and foremost, this oration would not have been possible without the guidance of my teachers and mentors who identified and nurtured me throughout my journey from pre-intern days to the present days as a senior registrar. I wish to express my heartfelt gratitude to all of them who are present here and those who are absent, who blessed and guided me throughout my clinical and research endeavors and always wished for my success. I thank all the research assistants who worked tirelessly in collecting data and ensured that all projects undertaken were completed in a timely manner. And with their perseverance, most of the time the projects ended up as index journal publications. Next, I thank my past and present colleagues who encouraged and supported me throughout my clinical and research activities and ensured that I achieved the targets optimally. Thank you very much, guys. Last but not least, I wish to thank my family for tolerating and supporting me unconditionally throughout my journey, through thick and thin, so that I achieve the best. Thank you very much, ladies and gentlemen, for your kind attention, and I wish you all a very pleasant and eventful day.